Hello, this is Nick Macklon, Professor of Obstetrics and Gynecology and Medical Director at London Women's Clinic. I'm very pleased that you've been able to join me for this short webinar where we're going to be talking about fertility options for same-sex couples. And I think it's worth stating at the outset that treatment of same-sex couples has become extremely mainstream in recent years. And London Women's Clinic, I think, has been one of the pioneers in forging the new options that are available for same-sex couples to have children together. And in the next few minutes, we'll be reviewing what those options are. So, as you can see from this map, London Women's Clinic has a number of centres around the UK. We have hubs in Darlington and Cardiff and in London, and we work together with our satellite clinics to increase access to patients looking for treatment from a broader part of the country. Here in London, we have our main IVF lab, and this is also where the London Sperm Bank and the London Egg Bank are located, although we are able to recruit donors from across the country through our various clinics. So what are we going to talk about today? Well, I'm going to start by just reviewing some of the basic biology that we need to remember when we're thinking about trying to conceive for same-sex couples particularly. And then we'll talk about some of the treatment pathways that are available, how we initially investigate the couple and what those particular treatments might be, how they work and when they might be indicated. We'll then talk about sperm donation, and we'll talk about egg donation as well. And finally, we'll finish by discussing some of the support that's on offer, and that is a very important element of care. So let's go back to the classroom from O-level biology, or possibly even before, and just remind ourselves of the female anatomy when it comes to reproductive organs. Because it's important, I think, to be able to understand what's going on during fertility treatments and why sometimes they might not work even, and why sometimes they do. And if we start with the anatomy, you'll see in the center there the uterus, which is normally the size of a tangerine to orange, I suppose, and is connected to the ovary through the fallopian tubes. And the fallopian tubes lie close to the ovaries. So when an ovulation occurs each month, the fallopian tube is able to pick up the egg that's released by the ovary and allow its transmission into the uterus. And in a conception cycle, on its way down the fallopian tube, it'll meet a sperm cell and their fertilization will take place. And the newly formed embryo will start dividing and pass down into the uterus, where we would hope that it will implant around about 5 days, 6 days after fertilization. So clearly, for that to happen in the normal situation, the ovary needs to be releasing an egg. The egg needs to be able to pass down through the fallopian tubes and into the uterus to implant. In the context of same-sex couples, there are two primary ways why that might happen. The first would be by delivering donor sperm directly into the uterus through intrauterine insemination, which we'll be talking about in a minute, or by removing the eggs and then fertilizing them with donor sperm in the laboratory, and then passing the resulting embryo up through the vagina, through the cervix, into the uterus, where we will, of course, hope that it implants. Now, there are many factors that determine whether or not a fertility treatment will be successful in this context. And one of those which perhaps we're most aware of, and which in many ways is the most challenging, is the age of the woman who's trying to conceive. And this is reflected, I suppose, in this chart, which reminds us again of some more basic physiology. And that is that there is this reduction in egg numbers in the ovaries through life. Women are born with all the eggs that they will have. And right from even before birth, they start losing eggs every month from the ovarian pool. And of course, over a period of time, once they reach puberty, one of those eggs that will emerge from the pool each month should hopefully mature and ovulate, while the other ones that will be leaving the pool will go into atresia. And over a period of time, the ovary will lose its numbers of eggs and on average will tend to run out at the age of about 50, 51, and that is the average age of the menopause in the UK. But on the way, there will be a couple of reproductive milestones. And the first one you see in this slide is the period of optimal fertility. That is the age range where we think that the quality and number of the eggs is at its best, and therefore increases the chance of spontaneous conception and indeed fertility treatment working over other age groups. And this remains quite good until 37, 38, where it begins to fall a little bit more significantly, such that in most women, their period of spontaneous fertility will tend to end in their early to mid 40s. And this, I suppose, reflects one of the big challenges we have when we're trying to help same-sex couples in conceiving, because there is an issue sometimes with the number and the quality of the eggs that are available for us to use to inseminate and hopefully to cause a pregnancy. That, taken into account, is clearly a key factor, but there are many other reasons and many other medical factors that we need to consider when we're planning your treatment. And that is why it's very important early on in the treatment plan to have a consultation with your fertility doctor. And they will do a number of things. They will take your history and that of your partner. They will be looking for any signs of problems in your medical history, medications, operations in the past, or indeed in your family history, which could affect your fertility and your response and success of treatment. They will add to that with some investigations. They'll do a transvaginal ultrasound scan to look at the ovaries and the eggs to make sure that the ovaries are free of any gynecological disease that can be seen on ultrasound scan. And when I say look at the eggs, of course, we're not looking at the eggs themselves because they are too small to see in ultrasound. But what we can see is the follicles in which the eggs are growing. And every month, around about 5 to 20 follicles should be visible at the beginning of your cycle, containing the eggs, which will mature through that cycle, and one of which will result in ovulation. So alongside that, we will then also look at the uterus. And we will consider the thickness of the endometrium and how smooth the cavity lining is to see if there's any fibroids or polyps or lumps and bumps which might impinge on a normal implantation. The other result or test that you will see there is something called the AMH test. Now, AMH is a hormone, anti-Müllerian hormone, that is released by growing follicles in the ovary. So the more follicles you have growing in your ovary, the higher the anti-Müllerian hormone test will be when we measure it in your blood. Now that can be very helpful, but because there appears to be a correlation between the number of follicles actively growing in your ovary and the number that are left. And it can therefore give us an indication where you are on your personal reproductive lifespan or biological clock. In other words, if your AMH is very high, it would suggest there are lots of eggs still there. And if your AMH is very low, it would suggest that perhaps there aren't so many there and we should all be getting a move on with treatment. The AMH test can also be helpful to doctors in planning how to treat you and what dose of hormones to use when we're doing IVF, and we'll touch on that again in a little while. After you've had that consultation, the aim will be to make a plan of treatment. And depending on which plan of treatment we will be making for you, there may be some additional tests that we need to do. But for most treatments, there will be certain things we will want to check, such as whether or not you're up to date with cervical smear tests, whether you're rubella immune, and indeed whether you have suffered any infections with HIV, hepatitis B, or hepatitis A. If you are also going to be using donor sperm or donor eggs, the next phase will indeed involve choosing your donor, and we'll be talking about how you might do that in the next few minutes. Now, the other vertical column you'll see there has the word counselling in it, and that has a dotted line because there really is no fixed time when seeing a counsellor is absolutely required or always necessary. However, our counsellors are essentially always available at any stage of the journey to be contacted for support and advice. If you are undergoing egg or sperm donation, then we do advise that you do see a counsellor before starting your treatment to discuss the implications of your treatment, both medically and legally, but also psychosocially as you look to the future and consider the different scenarios that might arise. And it can be very helpful to have an opportunity to speak to one of our counsellors just to talk these through before you start the treatment. But as I've said, counsellors are available to support you and advise you throughout your treatment pathway. So here's a list of the tests that we will require. And these are essentially those that I've mentioned already: the AMH test, the ultrasound scan, the antral follicle count, and that is counting the number of follicles in ovary on ultrasound. And then the viral tests that I've mentioned there, chlamydia and the cervical smear. It is important when you're planning to treat your treatment to recognize that there is a time limit over which some of these tests remain valid. And therefore, if you're not planning to have treatment for 6 or 7 months, it might be worthwhile delaying having these screening tests, because we would need to repeat them again before you start your treatment if the delay is more than 3 months. But if you are planning to start within 3 months, of course, we will move ahead and get those tests done for you. There's a little bit more information here on this slide about the tests that we do, and I'm going to focus here on the ultrasound scan. And you can see on this slide a picture of an ovary with some black dots in it, black circles, and each one of those represents a follicle which is containing a growing egg. And you can see in this ovary there are 8 of those visible, so we would call that an antral follicle count of 8. And we can see that by placing an ultrasound probe within the vagina, and from that we can bring the ovaries into view, but also the uterus and bladder and other pelvic structures. It allows us to examine the endometrium, its thickness, the shape of the cavity, look at other anatomy and other potential problems such as fibroids and polyps, or even signs of endometriosis cysts. Occasionally, we may identify underlying fertility conditions such as polycystic ovaries, or we may see some evidence that the fallopian tubes may be damaged in some way, which might indicate that further investigations of the patency of the fallopian tubes would be necessary. Now, such a test is called the high COSI test, and this is something that's been developed which allows women to have their patency of the fallopian tubes, in other words, to make sure they're open, tested in an outpatient setting rather than having to go through general anesthesia as it did in the old days. And what this essentially involves is an ultrasound scan in which we pass some fluid, which has got some air bubbles in it, into the uterus, and those bubbles are very visible on the ultrasound monitor, and we can watch that fluid going up into the uterus and passing out through the tubes and emerging into your abdominal cavity. And when the doctor sees that, then they can be reassured that your fallopian tubes are indeed open. And if you're going for donor insemination cycles, there may be some comfort in knowing that that is the case before starting on treatment. And certainly if you've had a history suggestive that your fallopian tubes may have been blocked, either for instance through chlamydia infections or surgery or previous abdominal procedures, then it may be advised to you to have this procedure before embarking on donor inseminations. So let's switch now and talk to you a little bit about some of the treatments that are available. And perhaps the simplest and most straightforward is what we call intrauterine insemination or donor insemination. And essentially what's happening there is we're simply taking donor sperm, placing it in the uterine cavity at a time when we know that 1 or possibly 2 eggs have been ovulated and are likely to be positioned within the fallopian tubes, ready to be fertilized. Now, this treatment differs, I suppose, from the way in which normal intercourse happens, in the sense that the sperm isn't placed at the top of the vagina, but is sort of helped on its way into the uterus. In order to do this, we need to wash the sperm first to just get the best sperm cells in, and those are placed there. And then hopefully one of those sperm cells will fertilize the egg, and 2 weeks later, we'll find out that there's a positive pregnancy test. So quite straightforward, and the timing of this is essentially the same as a normal menstrual cycle. In other words, you'll start the cycle with your period, and after around about 10 or 12 days, we'll be able to carry out the insemination, and then we'll cross our fingers and hopefully find that you're pregnant. So that is the DI treatment. And when we think about the success rates from donor insemination, I think it's important to remember what we're trying to achieve with donor insemination. As a same-sex couple starting with insemination, it's a little bit like, shall we say, a fertile heterosexual couple coming off the pill and trying to conceive with a reasonable chance each month. And that is what we're trying to mimic with donor insemination. And therefore, the chances of succeeding in one particular month will be in the order of 5 to 15%, depending on how old you are. And we've also got to therefore remember that it might not work first time. And just as fertile couples will come off the pill, and if they don't get pregnant in the first cycle, they will just keep carrying on a few months. That, I think, is the right approach for considering donor insemination or IUI. And what this figure shows from our own data is, I suppose, evidence to support that approach. What you see on those curves there, those different colored curves, are different age groups. And the bottom curve shows the cumulative pregnancy chance or live birth per patient over 1, 2, 3, 4, 5 and more cycles of IUI. And what you'll see is that if those that don't conceive after one cycle will have a chance of conceiving after the second, and a slight chance of conceiving even after a third or fourth. But after that, things rather flatten out, so that the cumulative pregnancy chance in women above 40 having donor insemination will be around about 12%. Younger women have a higher chance, and it keeps rising right up until 5 or 6 cycles, so that a woman under 30 might expect to have a cumulative chance over 5 or 6 cycles of having a live birth from donor insemination of around about 30%. And these figures, I think, are important to bear in mind when you're discussing your fertility options, treatment options with your doctor. And because there is this sort of cumulative rise in pregnancies with more cycles, it's reasonable, therefore, that we offer our treatment cycles not just as single cycles, but also in packages. And 3 of those are listed there, either 3 cycles of natural, 3 cycles of stimulated, or indeed 3 cycles of donor sperm, for instance, from the LSB, from the London Sperm Bank. Now, what couples will sometimes do is elect maybe to keep it simple at the start, to have 2 or 3 cycles of natural cycle, and if that doesn't work, to move on to stimulated cycles. And stimulated cycles, what does that mean? Well, it means that we provide a little bit of support to the follicle growth. Some women will require that. Other women won't require it because they're getting their own ovulation, but there is some evidence that a bit of hormonal support may improve the quality of the egg and of the implantation. And that might be given either with tablets of clomiphene or letrozole for a few days early in the cycle, or sometimes with low-dose injections of follicle-stimulating hormone. There may be reasons why insemination is not a good idea. This may be related, for instance, if there's a tubal problem, so that the eggs can't meet the sperm in the body, or if, for instance, we're concerned that the age of the woman who's trying to conceive is such that the chances of IUI are felt to be too low, or it may be the case that the patient's had a number of cycles of IUI, it hasn't worked, and it seems appropriate to move to in vitro fertilization to increase the chance of that working. So let's talk then about IVF and ICSI. Well, what does IVF and ICSI stand for? Well, IVF is in vitro fertilization. In other words, fertilization of the eggs taking place inside a dish. And ICSI is a similar treatment from the patient's point of view, but a slightly different way of fertilizing the eggs. In that context, rather than placing an egg in a dish with around about 100,000 sperm around it and leaving the sperm to fight it out and for one sperm hopefully to find its way into the egg, with ICSI we give the sperm a helping hand. The embryologist will select a sperm cell and then place that within the egg through a very, very fine needle. And indeed, if you ever see IVF or ICSI being talked about on the news or on programs, they often will have a picture in the background of an egg with a needle sticking out of it. And that, of course, is showing the process of ICSI. But before we can do any of that, of course, we need to get some eggs. And how do we get hold of the eggs? Well, the eggs, of course, will be in your ovary, and we need to try and stimulate your ovaries so that in the month of the treatment, the cycle of treatment, rather than just getting the single egg that was destined to ovulate in that month, all of those eggs that have been maturing for a couple of months are now entering the final phase of maturation, will have the opportunity to reach maturity rather than just one. And in order to do that, we need to give some help with hormonal stimulation. And what the hormone stimulation does is it keeps your FSH level above a certain threshold long enough for all the eggs that have reached that stage, ready to go for the final maturation in your ovary, in the cycle which we will be remove the eggs, to reach that phase so that they can also potentially be fertilized. And that involves injections. And those injections are something that the nurses will show you how to do. It's very straightforward and quite often done using very simple pens into the skin on your tummy. And you need to reckon with around about 10 to 12 days of these injections. And during that period of time, we'll get you to come up a couple of times for a scan to see how you're responding to that hormone and whether the follicles are growing as we would wish and expect. During that time, we will also, after about 5 or 6 days, introduce another hormone. And that hormone is designed to stop you from ovulating all those eggs before we can get our hands on it. And that is important because if you were to indeed ovulate those eggs, then when we go and do the egg retrieval, we won't be able to fish them out. So those two hormones are very important. And when we reach the stage with the ultrasound scan that we're seeing follicles reaching diameter of between 15 and 20 millimeters, the doctor will usually think, yes, these eggs are reaching maturity and almost ripe enough for us to remove, and you will be planned for a procedure called oocyte retrieval. Now in this slide, it shows you a diagram of what oocyte retrieval involves. Essentially, we pass the ultrasound probe into the vagina up to the top, and attached to the probe is a very thin needle, which the doctor then passes through under ultrasound guidance into the ovary. And those follicles are now very visible and quite large, and it's quite straightforward for the doctor to pass the tip of the needle into each of these follicles and then apply a vacuum to suck the fluid out of each follicle. That fluid then goes into a little jar and gets passed through to the laboratory where the embryologists will search in that fluid for the eggs, and they will then fish them out. That'll be done in both ovaries and will normally take around about 20 minutes. This is a very standard surgical procedure. In the United Kingdom, we tend to do it under sedation. You'll be asleep for this. It is a surgical procedure, and every surgical procedure carries two risks, bleeding and infection, and that applies to this treatment too. But we have to remember that in this context, those risks are extremely small and readily manageable in the vast majority of cases at the time of the procedure, so you can just go home as normally. Once you've had the procedure and you've woken up, we'll be able to tell you how many eggs we've got, and we'll ask you to stay in the clinic for an hour or two just as you recover from it, and the nurses make sure you're stable enough for you to go home with somebody who can accompany you home. And that is important because, of course, you will have had a light anesthetic. The eggs are now in the laboratory, and the next phase is to fertilize them. And we do that using donor sperm. And that sperm will be prepared in the laboratory and then either placed alongside each egg in the way I described earlier, or we may use the ICSI technique to pick a sperm cell and place it in each egg. 18 hours after that, we'll hopefully find that fertilization has taken place. And what this slide shows you are the two techniques of fertilization, IVF and ICSI, and then some diagrams alongside that showing the different stages of development after fertilization has taken place, which the embryologist will be looking very closely at, because by monitoring that, they can assess the quality of the embryos and the likelihood of them implanting. So you see these 5 figures here showing a fertilized egg, one that started dividing, the one to the right of that. Now on the bottom row, one that's reaching 8 to 10 cells, it's around about day 3. And then the middle one on the bottom row is around about day 4. It's called a morula, and there you'll see that the cells are slightly less distinct before moving to day 5 or day 6, when we get what's called the blastocyst forming. And this is the embryo at the stage where we normally like to either transfer it or indeed freeze it for storage and transfer later on. So When we transfer an embryo, obviously we can do that in two contexts. One is in the cycle in which the embryos have been created, in which we call that a fresh transfer. And the other option we have, of course, is not to transfer an embryo, or to transfer one and freeze the others. And in recent years, the technique of vitrification has meant that we now have the ability to freeze and thaw embryos with great efficiency and reliability. And this technique of vitrification really is quite remarkable, because essentially it involves placing an embryo, or indeed an egg, because it can be applied to that too, rapidly into liquid nitrogen after preparing it for that switch into liquid nitrogen. And what we've found is that when you do that, then you avoid ice crystal formation in the egg or in the embryo. And we've known that ice crystal formation has been quite harmful to eggs and embryos, and has been perhaps part of the reason why the efficiency of freezing eggs and embryos has not been so good in the past. But it's now excellent, and that is due to this technique of vitrification, which, as the slide says, they get frozen into a glass-like state and can be stored for many years. We may decide together to do a transfer in the cycle in which the embryos have been created, or indeed thaw a frozen embryo and transfer the embryo then. In both situations, the technique of embryo transfer is the same. And this figure shows how it's carried out, in that a small catheter is loaded with the embryo by the embryologist, and then this is passed through the neck of the womb by the gynecologist, and then the embryo is placed around about 1 to 2 centimeters from the top of the uterus, normally under ultrasound vision. And quite often you will be able to see a little white dot where the bubble containing the embryo is visible in the uterus. This is a painless procedure in the vast majority of cases. But of course, it's a very important one, and that's why it's important that our doctors are all skilled in this technique, which I'm very happy to say, of course, that they most certainly are. So here's a summary of the IVF and ICSI pathway, which we've just been talking about, showing the ovaries at the top left-hand corner, they were stimulated with the hormones. At a time, we can then remove the eggs as we've described, we inseminate them with donor sperm, we get fertilization and hopefully the growth of one or more healthy-looking embryos, which we can either freeze and then thaw and transfer at a later date, or indeed transfer directly into the uterus, as we've described. Now, here's a slide that differs just in one element. And if you look at the bottom, you'll see an extra picture of an embryo with a little glass tube beside it. And it appears to be sucking out some cells from the embryo. So what's going on there? Well, in that photograph, what the embryologist is doing is removing a few cells from the outer part of the embryo, the part of the embryo that's destined to become the placenta once it implants, not the baby. And these cells can then be analyzed to see whether or not they contain the normal amount of chromosomes. And of course, chromosomes contain the genetic material that is required for a normal development. So what is the advantage of testing the chromosomes of the embryo? Well, we know that many embryos, although they look perfectly normal under the microscope, may have chromosomal abnormalities. And humans actually produce quite a lot of embryos with chromosomal abnormalities compared with other species. And these abnormalities are thought to underlie miscarriage in some cases, or indeed failure to implant. So what this information can do can help the embryologist in identifying the embryo that's got the best chance of implanting, and maybe change the ranking of the embryos in front of them. So where it has real value is in situations where there are a lot of embryos that could potentially be chosen to transfer, and which might be therefore transferred in a slightly more efficient order if the embryologist also has access to this information. And therefore, the time to pregnancy from the treatment might be shorter. However, there are patient groups where it's less useful, those with very few embryos, 1 or 2, for instance, where it would just be worth transferring the embryos and seeing if they work, of course, or in young women where we know that the risk of aneuploidy or abnormal chromosomes is very low. But it is something that you can discuss with your doctor if you are interested, and which they may indeed raise with you if they feel it would be beneficial to you. So let's have a look at a little video now. And what I'm going to show you here is basically what I've been talking about over the last few minutes, speed it up, so that you can actually watch some of these developmental changes happening to an egg that's just undergone fertilization. So the egg that you see in the dish here has been exposed to a sperm. And what we're going to see over the next few seconds is the process of fertilization visibly taking place, and then the divisions initiating, which will lead to what we call a day 5 embryo, one that's ready to transfer or freeze. So off we go, and we can see that this egg, which is within a shell, that sort of translucent circle on the outside of the egg, is very busy. All sorts of processes are going on in there. And what you're now seeing is that those two little circles within there are the pronuclei, and they contain genetic information from the egg and from the sperm. And they're sizing each other up now, getting ready to fuse, to produce a new genetic entity that will then be able to initiate division and become an embryo. And there you go. They've fused now, and this egg has now become what we call a zygote or an early embryo, and has started dividing here into just 2 cells. So the very, very first phase of human development. And over the coming hours and days, under the gaze of the embryologists as they watch this happening, they will be able to monitor this process that you're watching of egg division. And you can see these eggs, the embryo rather, has divided into 4 cells now, and probably 6 and then 8. And those cells, I think, all look very nice. They're of even size. And that's the sort of thing that the embryologist is looking at to satisfy themselves that this embryo is developing normally. So we're now looking around about day 3. This embryo is about 3 days old, and the embryos have continuing to develop and continuing to divide. And as it heads into 4 days, the division will continue, and eventually, actually, the cells will become quite difficult to make out. You can see there are now a large number, maybe 16, 24. They're continuing to divide now. And in a second, you'll see that they will seem to oddly coalesce. And that is when the cells seem to become less distinct from each other. That's happening now. And this is beginning to form what we call the morula. And this is a very important time in the embryo development, because at this stage, all sorts of communications are going on within the cells and between the cells before the cells determine whether or not they're going to become the baby or become the placenta. And what you're now seeing as we approach day 5 is that decision seems to have been made, and some cells are moving out to form the trophectoderm that will become the placenta. Those are the cells around the edge. And some are remaining in the center. It's called the inner cell mass, and that is the part that will become the baby. So what we now see is a beautiful blastocyst still within that shell. So it's still about the same size as it was when it was just an egg. And the next phase for this embryo, once it's transferred into the uterus, would be to hatch from that shell and then to start implanting. So we will then hopefully be able to place that into the uterus. Well, what happens next? Well, the embryo then has to interact with the endometrium. And I'm going to show you a short film that was made by one of my PhD students, Lotte Weimar. And what she did was she took an embryo, human embryo that had been donated for research, and placed it onto some endometrial cells, and did a similar time lapse to show you what happens as the embryo interacts with the lining of the womb. Sorry, and we'll just play that video for you. And this is a sped up, this is 18 hours in just a few seconds, and you can see that the embryo is sitting there, and the cells from the lining of the womb, the endometrium, recognize the presence of an embryo and reach out to it. So it's not just a process of the embryo invading those cells, but the cells from the lining of the womb, from the mother's side, recognizing the embryo, reaching out and drawing it in to initiate the process of implantation. So I think that's probably enough on the biology and the treatment elements of it. We've got to think a little bit now about you and your partner and how you want to conceive. And there are a whole range of options, as we said, the simplest being just insemination of one of you to use your egg, fertilize it, and hopefully it'll all implant in the normal way. But if we use IVF, then it is possible for both of you to be biologically involved in the creation of your baby. And this is through a technique that we call shared motherhood. Now, in this slide, we show you how that would work. So Mary on the right there doesn't want to get pregnant herself, but she would like to contribute to the making of the couple's baby. So what she will then do is undergo an IVF cycle and produce the eggs, and then in a kind of way donate them or give them to Susan to have them implanted in Susan's uterus. So once Mary's been through the IVF cycle and the eggs have been removed, they'll be fertilized with donor sperm. And then if we get an embryo, the embryo won't be transferred back into Mary, but instead will be transferred into Susan's uterus. And that allows both Susan and Mary to have had a very vital contribution to the creation of their baby together. So while Susan carries the pregnancy, Mary will have provided some of the genetic information for that. And many couples are finding this a very pleasant and very satisfying way to conceive together. There are a number of advantages, and as I've mentioned too, both will have a direct contribution to the pregnancy, either genetic or gestational. It allows same-sex couples to have more reproductive autonomy over their fertility treatment, in other words, to decide who will conceive and who will carry, and with whose genetic material. And it certainly has been rising in popularity and in many ways has become a preferred option for many same-sex couples. And because the eggs are coming from within the couple, it means that the need for donor eggs from an anonymous donor is lower. An example for that could be when there is a couple where perhaps one of the women has a lower number of eggs or is a little bit older and the egg quality is not so good. Well, she can conceive and carry a pregnancy using eggs from her own partner rather from a donor. And it works. This is data from our own center, which has been published in scientific journals, showing the good outcomes that we're seeing across the ranges, whether the age of the donor of the eggs or indeed the recipient. And it seems to be pretty good all the way through. What you can see is that the numbers of people who've had the treatment above 40 are small, so we need to be a little bit cautious about how we interpret that, but those who've been through the treatment have done very well. So it does provide around about a 50% success chance, in other words, a 50% chance of getting a pregnancy after embryo transfer, rising to 67% in those between 30 and 34. So certainly encouraging and suggestive of a good way forward. The big question, of course, I suppose, when deciding to go whether it's for IVF or IUI is where are we going to get the sperm from, or indeed eggs, if they're necessary. Well, this is where our association with the London Sperm Bank and the London Egg Bank can be helpful. They're both located at our Bridge Centre in London, and they can provide sperm or eggs from a range of altruistic donors. It's also possible, actually, for you to use sperm and egg from other egg banks, either in the UK or indeed overseas, or it's possible to use sperm from a friend who's prepared to act as your donor, and indeed from an egg donor, if necessary, who you know. And that's what we call known donorship. Now, we operate under the regulator called the HFEA, and there are certain rules that they've stipulated for that sperm and egg donors need to meet before we can accept them onto our program. And this slide highlights those key rules for you to look at. So for sperm donors, they need to be under 41, and they need to make a commitment, because we don't just want one sperm donation from them. Ideally, we want several, so that they can father more than one child through their sperm donation process. It's very important to recognize that both sperm donors and egg donors are voluntary. They are not paid, but they do receive compensation levels for their time and inconvenience, which has been agreed by the HFEA and is thought to be reasonable enough to warrant, shall we say, cover the costs that they will make, but not so high as to encourage people to become sperm or egg donors for the money, as it were. That means that the donors are largely altruistic and do it purely because they wish to help couples like you and other couples to conceive. However, becoming a donor is not easy. In order to become accepted as a donor, you need to pass a lot of tests. These are multiple blood tests, screening for all sorts of conditions and infections in the past, and medical appointments to make sure that the people are suitable to be donors and also medically fit, healthy, and free from infectious and hereditary diseases. They need to obviously be identifiable in the usual way, and they receive a lot of counselling to understand the implications of what they're doing. And one of the key things they do need to understand is that in the United Kingdom, we take the view that children born after egg donation or sperm donation should have the right, when they become adults, to find out who the donor was. And that means that all the donors need to be prepared to have their contact details recorded so that they could be traced by a child in later years. Now, that obviously happens once the child reaches 18 or above, and that means that the donors do remain anonymous until then, both to you and to the child. Another element to understand is that there is a restriction on the number of families that can be created in the United Kingdom from a single sperm or egg donor, and that is 10. The reason for that is that it is felt that that number will allow a donor to help certainly more than one family, several families, but there won't be so many families generated from that individual donor that there would be a significant chance of the offspring from those families meeting each other and forming their own relationships, which would clearly be something we would wish to avoid. If we look at the egg donors there, you can see the age range is slightly tighter than for sperm donors, and that's because of the impact of aging on egg quality, which we talked about at the beginning of this lecture. And they have to make a commitment to ovulation induction, several visits for scans, and of course the procedure, which happens under sedation. And they will receive a lot of counselling in order to make sure they fully understand what they're doing. This slide just gives you an example of the selection process. So the London Sperm Bank will be approached by around about 8,000 men a year, but only 1 in 10 will finally end up visiting the clinic having had that initial screening. And then they have to embark on more screening to make sure that they meet the criteria for being accepted. And what this funnel shows is the main reasons why sperm donors might be rejected. 13% may not be medically fit enough. 54% their sperm will not be good enough quality. 6% may have an infectious disease that we can't allow to be present during a treatment. And 2% may have something in their history that suggests they have a very high risk of producing a baby that could be genetically affected. And 3% will decide themselves not to continue. And what that means is that from the original 8,000 inquiries, only 2% of men will make it as sperm donors to the catalogue. And that means that the quality of the sperm in the London Sperm Bank is excellent and is designed for safety. Now, how do you access that? Well, it's possible to go online onto the London Sperm Bank website and to see a range of profiles of sperm donors. These are the donors who've made the cut, as it were, and whose sperm has entered storage and is being released for use. And you will be able to read details of information about the donors, their ethnic background, education level, physical characteristics, and even some elements around their personal interests and education. And that can be helpful for you in trying to select a donor that you would be happy with. It is possible via the website to actually then reserve sperm from a donor that you would like to use. Or you can contact the London Sperm Bank, of course, by email or phone to discuss your requirements and for them to assist you in finding appropriate sperm. And what this slide shows you is that in a little bit more detail. So here's donor 1471. We can see he's Portuguese, Caucasian, his colouring is hazel, 1.78 meters high. He's an undergraduate at the moment, and some other details which you may find of interest. Now, in the United Kingdom, we're not allowed to show photographs of donors, but we are allowed to make descriptions of them, and you will sometimes find that there are little descriptions, as there are here, of the individual that's been made by our staff in the London Sperm Bank. And the donors are often encouraged to write sort of personal messages as well about why they wanted to become a donor and any good wishes or wishes they might want to pass on to you as somebody who might want to use the donor. And for egg donation, it's very similar. The London Egg Bank recruits donors. The eggs are removed and they're stored and frozen. And you can go online and you can look at the profiles of the donors in the same way as you can with London Sperm Bank. And here you can see a similar sort of profile as we had for the sperm donor. As I said, it is possible for you to bring your own donor to the clinic. And that might be a friend or a non-blood relation. And what that will normally mean, of course, that individual will normally only be donating to you. And because of that, we're prepared to sort of slightly loosen some of the strict rules around criteria for accepting into donation, because it's someone that you've particularly chosen to be your donor, and perhaps you're prepared to compromise on one or two issues, such as age. So for instance, men can be above 41 if they are known to you and you want them in the donor. And they might not necessarily have the greatest sperm quality, but as long as you understand that, then it doesn't mean that we will necessarily exclude them from a donor if you particularly want to try to get pregnant with their sperm. And the same applies for women, that our normal age limit of 35 can be adjusted if you have someone that you would particularly like to carry pregnancy from their eggs. And this will be decided on a case-to-case determination. We'll advise you as to how realistic it is that you would be able to conceive using your known donor. Donors can also come from overseas with, as long as they bring their relevant ID and come from a clinic that meets our requirements and those of the HFEA. The screening for known donors is the same as for our bank donors, so they do need to meet some of the same criteria in terms of infection risk and genetic risk, and will need to undergo a quarantine period. What that means is not that the donor needs to go into quarantine, but that once the sperm has been collected from someone who's HIV negative, for instance, we will then store the sperm for 3 months, retest the donor, make sure they're still HIV negative, and then, happy that that's the case, we will then release the sperm for use. And at the bottom line, you can see that counselling is important. And we've touched on that earlier, but it is very important that you fully understand the implications and expectations and legal implications of this treatment. And that's why implications counselling is recommended. This slide just reminds you that, yes, you can import sperm or eggs, but it does need to go through an administrative process to make sure they meet the requirements of the HFEA, and this can take some time. And one other thing to remember, of course, is that someone who's donated, for instance, in Denmark, their sperm might have been used to create families there, as well as perhaps 10 families in the UK. So that 10-family limit might no longer apply. And while in practice that will not be a concern for most people, it is something to bear in mind. So we've been through quite a lot of information over the last few minutes, and I hope it's been helpful to you as you start making your plans and decisions for your treatment. At the beginning, I did say how important counselling was and support, and it is. We don't forget at London Women's Clinic that for us, this is our day job, looking after people who are trying to conceive. But for our patients, it's a life event, and it has its ups and downs and can be quite testing psychologically. And that's why it's important that we provide support for you. And we're very lucky to have a team of counsellors led by Tracy Sainsbury, our head counsellor, and supported by Trisha Patel. And if you do feel at any point that you would like their support, then we can arrange that. And we can do it by Skype, we can do it in the evenings, we can fit around your schedule. So it is very, very flexible and hopefully will be nicely accessible to you. So that's really what I wanted to say today. I wish you every success as you make your plans for the future, and we look forward to seeing you at London Women's Clinic. Hello, this is Nick Macklon.